Okay. So I thought it would be good to start with, oh, hang on. Oops. A little bit about me. I was asked partly to talk about kind of the history of women's mental health care, and I thought I'd just explain who I am. So I originally studied philosophy at Yale. I specialized in women's philosophy, which was a new thing at that time. I decided to go to medical school in 1990, something like that, and I had to do extra courses post-bac in order to go to medical school. I started medical school at Baylor College of Medicine in 1993. I met my husband there. We got married very quickly and had our first child very quickly on purpose. I was kind of in a hurry because I was older. And then I had gone to medical school to be an OB-GYN. And I got into Baylor College of Medicine's OB-GYN program, and I completed 2 years and was in my 3rd year when I was pregnant with my second child and having a tough pregnancy. And the residency really didn't have any leeway for that kind of thing. And so I ended up leaving, planning to come back. But then I worked as a general practitioner and fell in love with kind of psychosomatic medicine, which I do feel is really my calling. Psychiatry is a better fit for me. And I was able to forge a specialization in the crossroads of mental health. Oh, can everyone mute? Great, thank you. And I've forged a really satisfying career doing reproductive medicine from the mental health side, working alongside OB-GYNs, doulas, nurse practitioners, midwives, and pediatricians. I lived in Colorado for quite a while, and I had the opportunity to be on the Colorado Maternal Mortality Review Committee, and I'm going to talk about that. I keep coming back to Texas. I can't seem to leave it for good, and my husband was offered a job that was really great, and our kids were just leaving, going on to college and medical school, actually. So we moved back to Texas in 2019. I had a mentor who was working at the clinic where I am now medical director at the women's place, and she hired me and then ended up retiring. Our clinic is called the Women's Place. The people who work in it are, the psychiatrists who work in it are all Baylor Department of OB-GYN faculty, and we're psychiatrists. So that's a very unique situation. Usually perinatal psychiatrists are within the psychiatry department of a college. And I think this is a wonderful opportunity for us to work more closely with the OB-GYNs. Along with our clinical work, and I have a list of things we do, we also are very passionate about education. We have medical student rotations in our clinic. We have a 3rd year OB-GYN resident do a rotation with us. A PGY4 psychiatry resident also spends 4 months with us. And then we also have consult liaison fellows who spend a quarter of their fellowship year with us. And we just started a women's mental health fellowship, and we're going to have our first fellow starting in July. One of the other things we're doing right now is we're starting something called Peripan, which is a network, which is a way for a primary care provider to speak to a reproductive psychiatrist and get in-time consultation. It is one of many programs across the country. MCPAP up there on the top right was the first, and it started as the program in Texas started. It started for pediatricians to have access to child and adolescent psychiatrists. It then expanded it expanded eventually to caring for moms, partly because the practitioners also could see when mom had a problem and how that impacted the children. So it's a natural extension of pediatric psychiatry to help moms. The Maternal Mortality Review Board that I was on in Colorado is one of many in many states in the United States, and some cities even have one. And what we did is sat down around a table and went over cases of a woman either during pregnancy or in the first year postpartum who died, and look over her case and try to categorize the cause of her death and whether it was pregnancy related or not. And what Colorado came up with is the fact that 28% of the time, a woman in the during pregnancy or postpartum period died due to her mental health issue, perhaps suicide, perhaps something else. In that is also substance use disorder, so they didn't break it apart. In Texas, we have data from 2013 and also 2020. In 2013, the committee found that 13% of deaths of moms in the first year postpartum were related to mental disorders. And in 2020, they broke that down to mental disorders and then substance use. So that's the bottom right. 16% of pregnancy-related deaths were due to mental disorders, and 7% were due to substance use disorders. So learning this has really made the argument for the medical community to pay attention to mom's mental health. I wanted to do kind of a quick background of postpartum or of perinatal mental health. And so I'm going to kind of race through it. I hope all of you have had some exposure to perinatal health through your medical training. But basically, this slide is showing that there are massive physiologic changes that occur during pregnancy and then right before or during or right after delivery. And we think that this is one of the big causes of mental health issues in the postpartum period. This slide is looking at research at moms during pregnancy. So the x-axis is months before or after childbirth. And you see number one kind of in the middle is when they give birth or give birth in the first month postpartum. And then on the y-axis are percentile of out of 1,000 women who had to be admitted to a psychiatric hospital. And as you can see, there's this massive increase right after birth, and it doesn't go back to normal in the first year postpartum. Perinatal depression and anxiety are the most common disorders in the postpartum period. The statistics, pretty much we say 1 in 8 women, or 15% of women, will be affected by depression or anxiety. The important thing here is that women don't self-report, and that's why the question of should we screen, and if so, does screening help the patient get care? And that has been a whole line of inquiry within the field that showed that if you screen and you don't have resources for the mom, it doesn't help her. If you screen and you have resources, it does. And that's why we're doing things like the Peripan project. I want to talk about some interesting, very specific perinatal mental health issues. Postpartum OCD happens twice the prevalence during pregnant or in the postpartum period than in a woman's life generally. So double the risk in the postpartum period of having OCD. And there's a specific flavor to postpartum OCD. The moms often have intrusive, disturbing, ego dystonic, so discordant from their beliefs and who they know themselves to be. Thoughts or images of something bad happening to the baby. Common ones are dropping the baby or stabbing the baby with a knife. And a lot of moms, when they experience this, have a lot of shame. And they also think that they're turning psychotic and that they're going to be one of the women who kills their baby. When in fact, what the medical community needs to know is these women are not at risk for hurting their babies. They're at risk for poorer bonding because they're avoiding their babies, because they're afraid of doing something. It's easily treated with a serotonergic agent. And so it's a very rewarding thing to help educate a postpartum mom experiencing this, educate her about it and treat her and get her better. The other important thing to know is around pregnancy and bipolar disorder. A lot of women will have that episode that you saw, the increased hospitalization rate in the postpartum period. A lot of women will have their first episode of what turns out to be bipolar disorder in the postpartum period. If a woman knows she has bipolar disorder and she goes off her medicine, she is at very high risk for having an episode. So the x-axis is time following conception during a pregnancy. The y-axis is the proportion without recurrence. So the lower the line, the worse off. That's a bad outcome. That's fewer women staying well. And you can see our medicines really make a difference. And women with bipolar disorder are at high risk for illness during pregnancy and also in the postpartum period. I'm going to keep moving. The other thing that women with bipolar disorder are at risk of is developing postpartum psychosis. Postpartum psychosis is by definition triggered by childbirth, and it's been designated an orphan disease as of 2016 in that it's rare and it's still not officially recognized. There's an overlap between women with bipolar disorder and women who have an isolated episode of postpartum psychosis. And there's confusion in the medical community where people think if a woman gets postpartum psychosis, that means she has bipolar disorder, and that's not true. They're highly correlated, but some women have isolated postpartum psychosis episodes. These are some, now I'm going to back up. We're not talking about bipolar disorder in pregnancy anymore. We're talking about any kind of mental health treatment, including involving medication during a woman's pregnancy. The basics in perinatal psychiatry are that both psychiatric illness, exposure to mom's psychiatric illness, and exposure to the medication are each a risk. And so you're trying to figure out, you're weighing the risks. There's no safe choice. Either way, there's a risk. There has been so much research done on our psychiatric medicines, partly because people have assumed they're voluntary or not completely necessary due to the stigma around mental illness and misunderstanding it as something that is not a real illness. The other thing is that a lot of people think that a certain SSRI is safe during pregnancy or safer, and that's not actually true. With SSRIs, any of the SSRIs are safe to use. And again, there's just oodles of research. The basics of pharmacokinetics in pregnancy, we're getting into the weeds a little bit. I'm not going to talk about this too much other than to say pregnancy is a very specific state where there's hypermetabolism occurring and also a great expansion in a woman's blood volume. When a woman is pregnant, she initially has very high levels of progesterone. This progesterone relaxes her blood vessels, and her heart, in order to keep up cardiac output, has to, the body bulks up the blood volume in order to fill the highways in our body. So basically, even in the first trimester, a woman who was doing well on a certain dose of medication before she got pregnant will possibly need an adjustment, an increase during her pregnancy, even in the first trimester. I just wanted to bring up, in discussing whether to go on and say an antidepressant for a woman, part of the things that get in the way of a woman being able to make kind of a free decision is she feels that it's either her health or her baby's. And that she's going to harm her baby if she takes care of herself. And that's a false zero-sum game. It's not a zero-sum game. We know now a healthier mom mentally means a healthier pregnancy. Family members who are not supportive is a big barrier. And then there's just the stigma of taking a psychiatric medicine. As you can see here, 15% of women will discontinue an antidepressant, 4% will discontinue their their medication for, say, GERD. These are things that can help a woman make a decision. Having interpersonal supports who are educated or just supportive of her taking medicine, access to a specialist, having such severe symptoms that they're not able to function on their own. And one study talked about this point of relative clarity, where they acknowledge, I clearly am not able to function and I need to take medicine to be okay. And finally, accepting that this is a complex decision, there's no risk-free outcome. However, we have enough data that's reassuring to encourage most moms to take medicine during their pregnancy if they need it. I just wanted to say breastfeeding, there are lots of resources for assessing whether a medicine is safe to use during pregnancy. During breastfeeding. I'm not going to go into this other than to just give you these resources, and I'll definitely share my slides with everybody. I'm going to shift gears and we're going to talk about menopause now, because this is a really understudied, underappreciated time period for a woman to also have mental health problems. Estrogen is very active in the brain. It is considered a neuroactive steroid. During perimenopause, when a woman is initially has lower progesterone levels that can cause, say, insomnia, and then reducing estrogen levels that lead to things like vasomotor symptoms, and also cognitive effects and insomnia and mood changes, irritability, anxiety, depression. There are women who have committed suicide during their menopausal transition. This is a cool slide introducing you to the biological mechanism of how vasomotor symptoms occur, so hot flashes and night sweats. Basically, there are these cool neurons in the brain called candy neurons, which I love that marketing. And they're called candy because they have receptors for 3 different proteins, starting with K, N, and D. They are also downregulated by estrogen. So when a woman loses estrogen, these neurons get overactive and they create havoc with the thermoregulatory center. This was just published. It is an opinion piece, But basically, I agree with what they're saying, that we lost our way with treating menopause, and we need to pay attention to it now. Basically, what happened is there was a big study of women in the 90s using a certain kind of hormone replacement therapy. And the women, they chose women who were 10 years and beyond menopause. So there is a downregulation of sex steroid receptors when a woman goes through menopause. And then they were adding back the sex steroids too late, basically. And what the study was halted early because they identified negative outcomes, including increased breast cancer, endometrial cancer, and thrombotic events. Sadly, these people were followed, well, not sadly, but the women in the study stopped their hormone replacement, but they were still followed. And what they found, what subsequently, is that there hasn't been an increased risk for cardiovascular or cancer mortality. And but the study really hit America hard, and hormone therapy dwindled to where it is now. And basically, we're at a point where we need to start giving the new data that basically supports and encourages hormone therapy, hormone replacement therapy. The timing is important. This study is a very good one, comparing those early perimenopausal women or early postmenopausal women with that cohort of women who are older. And what they found is it's not good to add hormones back when a woman has gone through menopause and is solidly postmenopausal, but it can be very helpful to use hormone replacement therapy in the early perimenopause. This is from a 2017 position statement by an organization called the North American Menopause Society. And basically, I'll let you read it for yourself, but it's very convincing that overall quality of life, overall mortality rate are both affected positively by hormone therapy. The other issue is that the metabolic changes that cause a metabolic syndrome in the perimenopause can be halted. And we're still trying to figure out if it also is, using HRT, hormone replacement therapy, prevents the development of dementia. Risks of hormone therapy are much lower than we thought. I'm just going to say that, and I'm happy to answer more questions. The only contraindication to taking estrogen is if a woman has had breast cancer herself that was estrogen receptor positive. Perimenopasal depression is high. In this study, which is a cross-sectional study, 50+% of women reported depressive symptoms during pregnancy, a rise from about a quarter to a third of women. Women who have a history of depression are at higher risk for depression during menopause, and also having vasomotor symptoms and insomnia seem to be related to depression as well. Cognitive issues are a very real thing during menopause. There's a transient deficit in learning and also deficit in memory. And there are really cool studies using brain imaging that define what exactly happens. I won't go into it here, but it's an area of hot research. This is about anxiety during perimenopause and just the sort of psychological distress. Irritability is a big one. Pharmacologic treatment of menopause is basically antidepressants or hormone replacement therapy. Now I'm going to switch gears and just sort of take us on a deep dive. I am a humanities person at heart, and part of what drew me to medicine was really wanting to be a woman healer. in the way that I'd read about in college. And basically, there's a lot of evidence that when a culture shifts gears from a kind of primitive culture where women are assigned a lot of power and generative power around having children, when there is a turn to patriarchy, or men basically holding power in the culture, you have a diminishment of women. And Joseph Campbell, this was a very hot topic in the 80s. And he basically is somebody who kind of spelled this out, that there's been a stepwise turn from basically goddess worship to male god worship. Themes in patriarchal societies often have to do with misogyny and sort of blaming women for things like the Garden of Eden. In the Garden of Eden, you know, Eve is the one who took a bite at the apple. There are many other cultures that are patriarchal that have similar stories. And interestingly, part of this shift to a patriarchal society is the removal of practicing medicine or practicing healthcare from women. Interestingly, in the Greek tradition, you can see this early on, 2000 BCE, women were seen as healers. And as the culture matured, there is a downgrading of the women who were identified as goddesses of prevention of illness and supportive health, for example. And instead, there's a rise of the male healer. In medieval Europe, basically, it was a really dark time for medicine. On the upper right corner, you can see bloodletting. That basically was the main treatment for people, was to get rid of the bad humor by draining them of their bad humor, which, as we know now, was not a good idea. It wasn't a good time for medical research, and basically sort of the practice of medicine got frozen from Roman and Greek practice. Texts from the East made their way back during the Dark Ages through, in particular, certain ports. There was one woman, we're not sure if she actually existed or not, or whether she's sort of a composite, but there were still women healers who were identified and followed. And this person, Trotula of Salerno, had a gynecological textbook that was used extensively. Just wanted to do a shout out for all the poor witches identified in the 1400s and 1500s in Europe. A lot of them were healers and midwives. I'm just going to shift gears. I love history. I'm going to throw some things out. Semmelweis, I hope you all have heard of him. He was a prickly Hungarian doctor who was working who came to work at the prestigious Vienna General Hospital in the mid-19th century. And he started to, he did an epidemiological study of the cases of puerperal fever or endometritis after delivery. And what he saw, as you can see on this chart, is over time, as doctors started to do autopsies on women who had died from endometritis, they didn't wash their hands because they didn't know that they were going to bring whatever bug the dead woman had to the next woman that they were delivering a baby or examining. So in the general public, puerperal fever was known as the doctor's plague. And there was a very clear association between having a baby through a doctor and getting infected, as opposed to going to a midwife where they weren't doing autopsies. So they were not carrying bugs to the live women. Louis Victor Marseille also practiced in the mid-19th century. He devoted himself to working in a woman's sanatorium, and he described in great detail a lot of the perinatal mental health problems that we know of today. There is the biggest organization we have in reproductive psychiatry is called the Marseille Society. Now we're coming into the 20th century and more history that I've actually lived. There was one male psychiatrist who in 1962 wrote the first book identifying perinatal depression and perinatal mental illness as something that needed to be looked at. And as an older man, he founded the Marseille Society, and then he also co-founded, along with a woman psychologist, the Postpartum Support International group. Our Bodies, Ourselves, this is a huge event that occurred. There was in the 60s, there were a lot of sort of awakenings happening and in particular, women were getting together and trying to empower themselves, basically. It's the beginning of the feminist movement. And there was a collective of women in Boston who put together a book called Our Bodies, Ourselves that basically had more holistic care for women's health. And it was huge. I had it as a college student, and it made a big difference for me, and it's partly why I do what I do. Women's studies became an area of study starting in the late 60s, and the mental health community woke up to the fact that sex differences and gender roles were important to look at, and also that we needed to study sexual and reproductive life of women. This was a huge book. I took a class in college called the CrossCultural study of birth. That is the other reason I got into perinatal psych. And this woman went and lived in the different, she did an ethnological study where she went to the areas that she studied. So she went to the Yucatan, she went to Holland, Sweden, and then of course she was American. And she wrote about the general approach to childbirth and the view of pregnancy. And she identified some things in the US that were negative, that in the US in particular, women are identified as a patient during pregnancy and childbirth. In Holland and Sweden, they weren't viewed that way. They were viewed as a sort of natural event in a woman's life. The locus of control in the US particularly was held onto by the medical community. And also infant mortality rates were higher at this time in the US than anywhere else. I mean, I have to say Yucatan had very high mortality rates. So we're comparing mortality rates in the US as opposed to Holland and Sweden. Postpartum Support International is a growing organization. If y'all haven't heard of it, go look it up. It basically is a group of mental health providers who have been producing more and more resources and access to mental health, perinatal mental health specialists. It's massive. I wanted to put a shout out to the Massachusetts General Hospital program. They have produced a lot of the research, not all of it by any means, but a lot of research showing that pregnancy is not a time of well-being for women, which was the prevailing thought until the 90s. And they produced very high quality studies that have informed how we practice reproductive psychiatry today. It's more and more, I'll tell you, the Brook Shields book came out in 2006, and it was kind of a scandal. And she got a lot of flack. And people, she got a lot of judgment from the world. There wasn't social media at the time, so it wasn't as awful as it could have been. But she was brave and wrote a book about her experience with postpartum depression. Now, so many celebrities are coming out about their perinatal depression, including Britney Spears recently in a Twitter post. And these are the organizations that I recommend you all look into. And if you're interested in reproductive psychiatry, these are kind of some of the most active and sort of central organizations. And then I just have some other recommendations. This is a podcast by a neuroscientist, Jody Paulowski, and she interviews different researchers about what we know about the neuroscience behind perinatal mental health. And then just recently, there was a really good piece on the history of abortion in America. And because of what's going on in the world in the US right now, I felt I needed to put that there as well. It's a very good piece. It's about 8 minutes long. So I am done. I am happy to open it up for discussion.
Thank you so much, Dr. Horst, for that very informative talk. And it was great seeing how the humanities have influenced your interests and your work. If anyone has a question, please feel free to unmute yourself. I'll also be looking through the chat for questions as well.
Hello, Dr. Horst. Thank you for that presentation. I found it very fascinating. I was not aware of this field before. Something I am curious about is if you, in this line of work, run into situations where women may face difficult news during the pregnancy. For example, news that perhaps their unborn child will have some sort of significant developmental or physical disability, and how this may impact their mental health, either women with no pre-existing mental health conditions, or how it would affect management of women with, say, depression or anxiety.
So yes, that is a big part of what a reproductive mental health provider has to help patients with, is loss and also sort of diagnoses of their fetus that are either devastating or just bad news. It's a big part of what I do. As far as it clearly, depending on the woman, miscarriage, even early miscarriage, is associated with depression that can, if not processed, can really hold a woman kind of hostage. So learning to grieve a loss of a pregnancy is something that we try to help patients with. And then, yes, devastating diagnoses. Now that I'm working in an academic center, I do a lot more of that, where I'm working with women who are having a hard time adjusting to whatever diagnosis they've been given, or they develop anxiety or depression around it. So it is very prevalent.
We have a question that asks, what are your thoughts on OB/GYN or family medicine doing postpartum depression screenings for every postnatal patient?
As long as that provider has resources to give the woman, I'm a fan. And studies have shown that. So it just depends on whether there are resources. And that's where organizations like the Postpartum Support International Group come in, because they have support groups, they have links to providers, they provide training for perinatal mental health workers. They're doing a lot of work around providing more resources. I was just in a meeting for that group, Peripan, and there was a recent study looking at how many women are actually getting treated. And it was very depressing. It was in the single digits for women actually getting treated for an identified depression, postpartum depression. So we have a lot of work to do. However, screening women helps them understand that they're struggling with something real and not just it's hard being postpartum.
So another question from the chat.
Yeah.
Or if you can see it, that's fine too.
I see it. So the question about Zoloft and birth defects, basically any study that comes out needs to be seen in the context of the vast number of studies that have come out on, say, Zoloft during pregnancy. So it really depends on the researcher and how good they are at excluding confounding variables. Depressed women tend to be heavier women, tend to smoke, tend to use alcohol during pregnancy, for example. And those are confounders that need to be accounted for in any kind of statistical assessment of causality or between Zoloft and say a birth defect. I can tell you, I mean, there's so much research on the SSRIs, and overall, the conclusion is they do not cause defects. Next, and I'm happy to discuss that more if y'all want to have a follow-up question on that, because that's obviously something that's very important to get clear on. Kelly, do you want to keep going then?
Sure, we can move on to the next question. They can always type something new later.
So the next question is about what people in reproductive mental health are doing to speak up. And I'm reading the whole question. So what I can tell you is one of the risk factors for postpartum depression is having an unintended pregnancy. Pediatric mental health is highly dependent on the mental health of the mom. Basically, I think statements are going to be coming out. I can tell you in my institution, which I'm in Texas, which has, banned abortions. It's been overturned for the moment, but it's a very hot issue here in Texas. What we see is women who, feel trapped. We see a lot of women who have a devastating diagnosis of their fetus, who fly to Chicago, New York City, Arizona, Colorado to get abortions. There are funds for women who want to abort and do not have the means to travel to a place where they can do it. Until we solve sexual violence among other things, and high mortality around childbirth, we need to have abortion be an option for women, is my view. Next question. Let me try to expand the chat real quick. As far as comments from organizations, I'm sure they're coming. I haven't seen them yet. I can tell you in my institution, we are organizing to figure out what we want to say. Our chairman doesn't want to say anything until it is actually law. So next question, the approach to working with women with chronic pain on high dose opioids during pregnancy, or women on ADHD medicines during pregnancy. So substance use disorder during a pregnancy is common in the US. And there are specialists in substance use who also specialize in working with pregnant women. And we have that in Houston here. I am not a specialist in that. I need to be, but it's just not, I haven't gotten there yet. But there's a move right now to start screening every mom for substance use disorder in a more organized and way. And we need to have treatment available for them, basically. I can tell you women can use methadone during pregnancy or Suboxone. And that's the ideal situation, is to switch someone to a medically assisted treatment for their opioid use disorder during a pregnancy. Women can take, if they are on opioids, they can continue them as well. Regarding ADHD medicines, that is being studied. The Mass General Hospital has a registry for women who take stimulants. We don't have a lot of data on the safety of using stimulants during pregnancy, and therefore the ongoing wisdom is try to go off of it or reduce your dose. That's kind of where we are. That's an area of growth in reproductive psychiatry. Let's see, just looking for anything else. Is there any more risk than the average population on pregnant women with neurodevelopmental disorders or who have neurodiversity? More mental health risk in particular? Is that it? I don't know of studies. You should do a study on that. I can tell you I've seen women who have who are on the spectrum, and I manage them the way I manage anyone. I don't know that there's a higher incidence of mood disorders with that, but that's something I haven't run across in studies. And then any advice on if you end up in a psychiatry residency that doesn't offer perinatal psych training? So the organization, the National Curriculum in Reproductive Psychiatry is free, and it's very extensive. And so you could bring that curriculum to your residency director and propose that you get training that way. Okay. Regarding incarcerated women, that's a very good question. That's probably another area that hasn't gotten the attention it needs. I can tell you in Houston, we have a wonderful psychiatrist who does treat that population. So it's going to be dependent on your, really down to, do you have somebody who wants to do that work? I guess is what I'm going to say. As far as resources, I mean, apart from, well, you know what? Actually, I have great news. Postpartum Support International is getting ready to have a telehealth platform where women can basically get treatment through telehealth during the perinatal period. So if you are still in Georgia, I suggest that you bring that to the attention of that OB-GYN. So it's through Postpartum Support International. Let's see, and then any single set of guidelines regarding psychotropics and pregnancy, different literature and organizations often have conflict. Yes, that is a problem. It's still a fairly new field. There are textbooks on it, so they exist, but there's a lot of misinformation within the medical community still, and you have to dig a little bit for the resources. They're there, but you have to look for them. But I can say, you know, Up to Date has good information on these treatment of mental disorders during pregnancy, for example. So we need more training for medical professionals, but there are resources. Let's see, how do you view the role of perinatal psychiatrists towards addressing the mental health of fathers? Yeah, that is that's something I wish I had put in my talk. When a woman has postpartum depression, 50% of the time, the dad is going to have it as well. Also, dads can get postpartum OCD. There is actually a pediatrician who developed postpartum OCD, and he now is on the board of Postpartum Support International, trying to spread the word. I'd say in my field, initially, it was pretty elbows out, men out. We want to take care of the woman. And it has shifted in the last 5 years to really recognizing we need to look at the whole family and help the dads, help the moms, and also recognize when a dad is struggling. So that is a kind of a frontier in my field. And finally, what would you say to trainees who currently live in progressive states? Yeah. Wow, that's a really interesting question. Gosh, I would say getting trained, I think you need to look at rather than looking at the state, you need to actually really look under the hood of the program you're looking at and see who the people are, and talk to fellow residents to find out kind of their satisfaction with what they learned, and maybe go at it that way. You know, I'm in Texas, which is at the forefront of things that I disagree with. But Houston is a little bubble of a lot of progressive thought. And so it's not, you know, it's beyond state by state to program by program, I guess is what I'll tell you. Okay, how are we doing for time? Oh, we're about out of time.
Yeah, if anyone wants to hop in with one final quick question, otherwise, I think we'll wrap it up.
I appreciate the opportunity, and I love your questions. I hope you had a good experience, and I'm happy to help however I can. Thank you. Thank you for all the thank yous. Appreciate it.
Thank you, Dr. Horst, and thank you everyone for being so engaged.
Yeah.
Yeah.
All right.
On the meeting now. Thank you, everyone.